Thank you very much. And it's a great honor for me to speak after this great speaker. And I would like to thank people from the Fundación Galicia Sur for making possible this seminar. And I'm going to talk about the relationships between dynamic contrast enhanced MRI and some parameters of this image, standard uptake value in PET-CT, ADC, and using all this information for modeling the treatment response and increasing the hypoxic-tumour control. Also, I would like to show to you some results that will be published in November, and these results are from the Artvibio project. In the last few years, a big amount of new radiopharmaceutical has been developed to see or to to shed a bit of light on a lot of human processes, human metabolism associated to a lot of biologic processes. If you look inside the university in the web of the University of Turku, you can see up to 43 radiopharmaceutical for different imaging. And in MRI, also, a big amount of technical has been developed in last year to allow us to see the tumor behavior, especially the ADC map that is for and the dynamic contrast enhanced on perfusion and bold. I think that those four techniques are the most important for our objective. If we want to see the tumor response, some radiopharmaceutical can be more specific than FDG, as timidine, tyrosine, or choline. And in MRI, probably the most typical is ADC map from diffusion-weighted MRI, and a spectrometry of choline could be useful, but the voxel size is too high to use in our purposes. And for measuring hypoxia, several specific radiopharmaceutical has been developed, as of MISO, CUPA-ATCM, EF5, VESA, and even dynamic FDG could be quite useful for this task. Well, in MRI, the most promising technique is bold blood oxygen level dependence, because it measures the difference in the paramagnetic moment of the oxyhemoglobin and the oxyhemoglobin. Anyway, this technique is quite difficult, and the image we get are really noisy, and we wasn't able to implement in our hospital. Then we are using FDG because it's available in our hospital and it's available in most hospitals in the world. Then the tools we develop can be useful in most hospitals. Dynamic contrast enhanced that give us a lot of parameters of the vascularization of the tumor. If we made a search in Google, in a scholar Google, for example, we can see that the number of published papers is growing and growing when we look at tumor response and radiotherapy. And if we compare in a relative way, we can see that diffusion weighting is approaching to the number of papers published with FDG. If we made a similar search about hypoxia, we see again that the most popular radiopharmaceutical is the most cited in the literature, and then if the FDG is again the most cited, even more than the specific radiopharmaceutical as of MISO or VESA. And also dynamic contrast enhanced has cited a lot in the literature. Well, I have a schedule of the ADR radiotherapy, but it's quite similar to that one that has explained Juliana. We can start with a simulation that includes all the information we have with the new diagnostic tools of the medicine, and we can get information about tumor cell density, radiosensitivity, or information from pathology. She is our pathologist. After that, we can start we can customize the treatment, and we don't need to deliver the same dose all the days to all the boxes. We can vary the dose for each voxel every day, considering reoxygenation and tumor shrinking. And we start the treatment, and we shrinking process start, and reoxygenation, revascularization, all the dynamic we would like to know. And we can control again the patient in the first day of the treatment, and we can adapt the treatment to the individual response. And we can adapt 1, 2, 3 times. And after that, we can make a follow-up image, again with functional imaging. And probably we have not delivered the amount of dose we are delivering now. Probably we can deliver less dose. Then the retreatment could be possible or not, but it's needed, could be possible. We cannot apply yet. Well, there is some technical reasons, like feasible registration for functional imaging is not fully achieved. There doesn't exist universal quantitative method in PET-CT and MRI. The number we have in our hospital probably are not the same numbers you have in your own hospital. And then we cannot share this information. We must adapt the radiobiological models we have to the information we have in the functional imaging. The radiobiological model uses number of cells, relative pressure of oxygen, days. Well, the time is the information we have. But the other two, we only have the standard uptake value in PET-CT, or the K-trans in a dynamic contrast, or the apparent diffusion coefficient. It's not the same numbers necessary. And when we have all this information, we can adapt the TPS to the biological information and get the authentic biological optimization. And finally, if we got all these tools, we need the clinical validation. The Amphibia project that is started in 2012 and will be finished now in 2015 is focused in the 3 first objectives, and we have requested a national. We have requested a proposal to a national call at Amphibia, and will be a start next year. Well, if we get funding, if we get funds. If we don't get, but we will don't start. But it will be based in the adaptation of the TPS to biological optimization. Well, I think that most of you agree with this sentence. PET-CT is the current standard in radiotherapy simulation. You can read a lot of papers about it, and you can use in your daily clinical practice. And I'm not sure if all of you agree with this sentence, but I'm going to try to convince to you that this is the truth. MRI is going to be the main tool in assessment of tumor response along treatment. In 2005, Lahendijk and Ray Marcus started a LINAC MRI project, and if you attend to an ASTRO meeting in the last few years, you can see this nice picture of this prototype. Next year, Chrome proposed a cobalt unit with an MRI, and only 2 years later it was commercially available. It was available by V-Ray. In 2010, INRIS and Varian started a joint venture and installed an MRI on rails, moving on the ceiling. The MRI is in the next room, next to in the room next to the treatment vault, and it's installed in the Princess Margaret Hospital from Toronto. And this year also, Tadic and Falone proposed a board biplanar permanent magnet for MRI. Last year, Electa, the NKI from Amsterdam, the UMC from Utrecht, the ND Anderson from Houston, and Philips signed a consortium to develop MRI-guided radiation therapy. And now the MRI LINAC is installed in the UMC in Utrecht, and probably in the NKI in the next month. Wow. It's not fast approaching, but it's approaching. Finally, this month, Tadic and Falone published the result of the MRI image of humans with her board biplanar MRI. Now I would like you to take a glance inside our project, Artifibio and Artifibio. Artifibio is the acronym of Adaptive Radiotherapy based on functional image and biological models. And we start collecting information from pathology and FDG previous to a treatment, and two studies. Well, it's the full study of MRI, T1, T2, ADC, diffusion weighted, ADC, dynamic contrast enhanced. And along the treatment, we also performed two another studies with dynamic contrast enhanced and with ADC. And 3 months after the treatment, we repeat the full initial study, All this information is sent to the Supercomputational Center of Galicia. We are here in Vigo, and they are in Santiago. They are 80 kilometers. And they put all this information for sharing to all the scientific community. And if we get funded, we will start next year with Artifibio. That includes another study in the initial simulation, an massive study, and then we can compare if dynamic contrast enhanced is a good marker of hypoxia or not, but we have two hypoxia markers. And we will include patients from 3 different hospitals. Here, Meixoeiro Hospital, Santa Creu de Sant Pau from Barcelona, and ERESA from Valencia. You can access to this web platform, and if you want to access to the information, all the studies of the patient, when they was did it, the dose distribution, the daily dose distribution. You can request your access to this email at artifibio@fesga.es, and you can see all the information we have. Now I would like to explain to you why we have chose these 3 data sets. The PET-CT, dynamic contrast enhanced, and diffusion weighted image. PET-CT, well, it's not doesn't really measure the tumor cell density or something similar, it really measures the glucose consumptions of each region. And tumor cells use glycolysis rather than lipolysis as the metabolic process to produce ATP. And they use more glucose than normal cells. Well, they use a bit of lipolysis, but not as in normal cells. It's not absolutely. Well. Glycolysis is a rather inefficient process, and therefore large amounts of glucose are needed for cell survival and tumor growth. The PENT enhancement in tumors is due to 3 different mechanisms. Cancer cells produce more ATP outside the mitochondrion, even in well-oxygenated conditions. This is called, and this is named, the Warburg effect. Moreover, cancer cells proliferate more than normal tissue cells, and they need more glucose. And cancer cells can survive in lower oxygenated regions, better than normal tissue cells, but they consume more glucose because they need to produce ATP by glycolysis in absence of oxygen. This is the Pasteur effect. And we have 3 effects for PET enhancement, 3 different effects. We can use a compartmental model to introduce all these parameters, and we can see that if you compare a normal cell producing all the ATP by glycolysis and a tumor cell producing all the ATP by glycolysis also, but considering the Warburg effect only, you can see that the tumor cell always consumes much more glucose than normal cells. And even more, the tumor cell can survive in no oxygen conditions, and normal cells cannot survive, and even in more acid conditions. Everything is related. The glucose metabolism, the acid environment, and the probability to survive in low oxygen conditions. Now I'm going to try to explain a bit of the process of diffusion-weighted MRI, but Beatriz will be explained more detailedly later. Diffusion-weighted measures the diffusion of protons in a medium, and is based on the attenuation of the signal according to a statistical Antoner's model. And tumor cells are abnormal in size and shape compared to normal cells, and they're more tightly packed and have higher cellularity than the tissue from which they originate. The extracellular volume is smaller in tumor region, and therefore the freedom of movement of protons in regions is restricted. Along the treatment, when the radiation impact in the cell, the membrane is broken, and water has more freedom for moving here. Then when we, along the treatment, we can see a shift to the right in the histogram of ADC. You can repeat this signal varying the applied gradient, the gap between pulses of gradient and the pulse duration, and then the logarithm of the signal attenuation is proportional to the apparent diffusion coefficient. And we can vary this B parameter, and we can obtain this curve, and after that we can calculate the ADC map. Many other authors have proposed diffusion-weighted MRI for treatment assessment. And Van de Café has proposed several, has written several papers about it. with chemotherapy and with radiotherapy. This is an example with chemotherapy only. And he has another with radiotherapy. And the advantage are the ADC is proportional to tumor cell density. It's not like glucose metabolism. This is directly proportional to tumor cell density. Allows comparison between different hospitals. You can use in any hospital you are. And it's a non-invasive technique. Anyway, it's not perfect. It presents a big distortion. And you can see here that the spinal cord in this part is correct, but in this part is not so pretty. But we think that there is a solution, that is the reverse gradient method. Well, this is, they apply in this case the the phase encoding direction in the lateral direction. If you apply the gradients in this way, you get this distortion. You can apply in the opposite direction. You can get a distortion map, and you can correct your image. We are working on it with our patient. And the third type of image we have is dynamic contrast enhanced. And dynamic contrast enhanced measure how the gadolinium is coming to the tumor. Some people has proposed it for tumor control assessment, but but it's more clear that CAT-trans or some parameters of this image can be associated with hypoxia. Here you can see this is the pimonidazole staining. This is similar to CAT-trans, but he doesn't use the Tufts model. He used another model, but it's a similar parameter. Here you have the inspection of the Tufts model, and we are using these two parameters from K-trans, that is the transfer constant from the blood plasma into the extracellular extravascular surface, and V, that is the extracellular extravascular volume. Well, we are now start to talk about the objectives of the Amphibio project. And the first of all is collecting data and sharing with the scientific community. And the second is finding the relationship between the different image modalities. We suppose that ADC is proportional to the tumor cell density, and the maximum tumor cell density can be obtained from pathology data. That is the patient, and it is the analysis we do with the image of pathology. The relative pressure of oxygen is a function of K-trans, and the FDG is a complex function of the tumor cell density, the malignity of the tumor, how the Warburg effect is present or not in this kind of cells, and the relative pressure of oxygen. With all this information, we would like to apply to analytical model, to radiobiological analytical model we have. And even more, we would like to go one step beyond, and we would like to build an in silico tumor that consider how the radiation in seed impact in every box cell, and the reoxygenation processes. I'm considering all this data in the radiobiological model. Well, now I'm going to show to you some results that Some of them are yet published, and the other will be published in November. Here you can see the shift to the right of the histogram of ADC map in the tumor, and how the ADC increased along the treatment. Well, in this case, we consider necrosis and hypoxia of the same patient. Necrotic tissue has a big ADC, like normal tissue, and then it's a bit complicated. This was a papilloma-positive patient, and then has a different response. Here you can see the variation of the oxygenation along the treatment. You can see here how this part of the tumors is reoxygenated, and the tumor is a bit shrinking. Oh, no. And here you can see some parameters can be redundant in all of this image. Here we compare the VE, the extracellular extravascular volume, from the dynamic contrast enhanced, and the ADC from the diffusion weighted image. And in the well vascularized areas, probably they are redundant values. And in the worse vascularized area, probably the VE has less meaning to use. It's more complicated. But in well vascularized area, we can use both ADC. Oh, no. We can use ADC or VE. Now I would like to show to you the relationship between all the three types of image and the dose. And the relationship is not as pretty as we would like, but we can see that some kind of relationship between these three parameters can be found. And here we are trying to explain, we have analyzed voxel by voxel, but not the whole image, only that part where we were sure that the registration was correct, where we have enough information. And here in the well vascularized area, we cannot see a clear relationship between CAR-trans and ADC map. And in the less ADC is more tumor cell density, more ADC, less tumor cell density. Here we cannot see a clear relationship, but in the hypoxic area, when we compare the K-trans with the standard uptake value in PET-CT, we can see a high value of standard uptake value. In the region where the vascularization varies, we can see a variation of the standard uptake value. It looks like that the Pasteur effect is working here. It looks like that K-trans is a good marker of hypoxia. Here we have a comparison between ADC and a standard uptake value, and we can see again that in the well vascularized area there is a variation of data corresponding to different oxygenation conditions, and in the hypoxic region they get the maximum values. And also, if we study the ADC along the treatment, this is the delivered dose, and this is the ADC, and we would like to see how the K-trans, like the hypoxia, modulated the response of the tumor. The less vascularized area has worse response, or less increment or in ADC, and the well vascularized area has a better, higher increment in ADC and probably a better response. The conclusions I would like to share with you is that we need to improve the flexible registration for diffusion weighted. but the voxel by voxel analysis seems possible, and the chosen datasets look like suitable for the initial proposals. ADC varies along the treatment and increase with dose. K-trans modulate the treatment response. When we compare with the standard uptake value from PET-CT data, it was similar to hypoxia. Standard uptake value of FDG is a marker of the malignancy and the other two phenomena. We also think that multimodality information gives more information than the simple addition of the 3 different data sets. Finally, multicenter studies are needed for increase the statistical power of the results. I would like to thank all the team, all the multidisciplinary team we are. We are medical physicists, radiation oncologists, nuclear doctor, radiologists, pathologists, people from the Supercomputational Center of Galicia, and researchers from the University of Vigo. Thank you very much, and I would like you to go here in Vigo.